let's talk about kidney endocrine or kidney hormone functions. So we have erythropoietin, EPO. It is released by interstitial cells in the peritubular capillary bed in response to hypoxia. So when you have hypoxia, it stimulates which cells in the kidney? Very important. They are the peritubular interstitial cells. Peritubular interstitial cells. If you were to draw a tubule, let's say this is a tubule, and you have these are your renal tubular cells, and this is the tubule, and these are renal tubular cells. You have the peritubular interstitial cells. Peritubular, these are the peritubular now. Peritubular interstitial cells. And what are these? They are the epithelial cells, the endothelial cells. No, they are the fibroblast. So peritubular fibroblasts. Okay, peritubular fibroblast. They release the EPO. So that EPO is going to stimulate the RBC proliferation in the bone marrow administered for anemia secondary to chronic kidney disease. They're saying in anemia secondary to chronic kidney disease, you're administering the EPO because you know that in CKD you're not making enough EPO, which is causing anemia. So administer EPO from outside so that it goes and stimulates the RBC proliferation and production. Okay, and patient with CKD or patients with CKD have inflammatory damage to these EPO producing cells. That's why you have normochromic anemia in CKD. Treatment, give outside EPO, and it's going to fix the problem. Okay, so when you give from outside, when you give the EPO from outside, or EPO erythropoietin supplementation, right? That is the epoetin or the darbepoetin. Those are the exogenous PTOs or supplements for the EPO. What do? They stimulate. They will stimulate the erythrocyte production, and which leads to increase in RBC mass, which causes increase in blood viscosity. So you know that when you increase the blood viscosity because of increase in RBCs, that hyperviscosity can lead to thromboembolic events. So like stroke, DVTs, venous thrombosis, and all that. Okay. And secondly, this EPO is going to stimulate the EPO receptor on vessels. And when you activate those EPOs on vessels, vessel means endothelium, right? Endothelials are the cells that are present in the vessels, and the smooth muscles are also present in the vessels. So EPO receptor are present in the endothelium and the smooth muscles of the vessels. This causes hypertension. So that's why when you give EPO, you have the risk of getting the patient into hypertension and also thromboembolic events. So that's pretty much all we have for EPO. Let's talk about the calciferol vitamin D. PCT converts 25-OH vitamin D3 to 125. So this is inactive form of vitamin D. It converts that to an active form, which is 125-OH, to vitamin D3, calcitriol, which is an active form of vitamin D. So who does that? PCT, kidneys PCT, right? So increases when you activate vitamin D. The function is that increases calcium absorption in small bowel. And they have mentioned in here the calcidiol, and which enzyme, very important, 1-alpha-hydroxylase. From the PCT, you release 1-alpha-hydroxylase, which converts this into a calcitriol, an active vitamin D. And PTH stimulates this 1-alpha-hydroxylase in the PCT. And once you have that active form, you can cause increase in calcium. Again, same thing. If you have CKD, they're not going to work. 1-alpha-1-hydroxylase is not going to work. PTH is going to come. There are no cells to work on. That's not going to work. Vitamin D is not there. So no more increase in calcium through vitamin D. Okay, so that's all what we have for the calciferol or vitamin D. Now let's talk about prostaglandins. Prostaglandins, paracrine secretion, vasodilates afferent arterioles and increases the renal blood flow. So it vasodilates the afferent arterioles. So NSAIDs, when they inhibit prostaglandins, they block renal protective prostaglandin synthesis, leads to constriction of afferent arteriole and decrease in GFR. So when you constrict the afferent arteriole, which is going into the glomerulus, right? You have constricted that. So now you have less blood flow. When you have less blood flow, you would have less volume going into the filtration, causing less GFR, glomerular filtration rate, right? This may result in acute kidney injury. When that's too low, it may cause an acute kidney injury in low renal blood flow states. Because if it is very low, if the renal blood flow gets too low, you're causing AKI, acute kidney injury. So now the other way to think about it, all this mechanism, so NSAIDs, acetaminophen, aspirin can lead to AKI via constriction of the afferent arteriole, decreases the blood flow going through the kidney, decrease in GFR, eventually leading to AKI. And it's also called, clinically it's called analgesic nephropathy. Analgesias causing nephropathy due to papillary necrosis and chronic interstitial nephritis. This leads to also papillary necrosis and chronic interstitial nephritis. Okay, so let's talk about dopamine now. Dopamine secreted by the PT cells promotes natriuresis. At low dose, now it's a dose dependent, low dose dilates the interlobular arteries, afferent arterioles, efferent arterioles, leads to increase in renal blood flow, but little or no change in the GFR. At higher doses, acts as a vasoconstrictor. So at low doses, it's dilating almost everything. Look, afferent, efferent, right? And interlobular, right? And increasing the renal blood flow because of that dilation. that is only in low states. But in higher doses, it's causing vasoconstriction. So in shock patients, if you want to protect the kidneys, they give dopamine low doses, so it maintains or gives no change in the GFR and maintains the kidney by causing vasodilation. Excuse me. All right, that's pretty much all we have for the kidney endocrine functions or hormone functions of the kidney.